my time, I'm a consultant in public health at Doncaster and Bath Law Teaching Hospitals, which is why I've got a Doncaster and Bath Law Teaching Hospitals background on at the minute. So yes, hi, and I'll be talking a little bit later on.
Hi everyone, I'm Naseeb. I'm a research associate at the University of Sheffield, and I'm also project managing PRAMS. So it's nice to meet you all.
Hi everyone, I'm Danielle. I'm a research assistant at the University of Sheffield as well, and research assistant on this project.
Thanks everyone. Should we go to the next slide? So in the seminar today, we're going to provide an overview of the PRAMS project. So just a bit of background, why we're doing the project, what it's about in terms of the aims and objectives, and then the 3 work packages. And then Naseeb and Danielle are going to talk through the early findings from work packages 1 and 2. And then we're going to consider learning points and next steps and reflection points with Kelly. Just to check, Naseeb, is Tasleem or Sahara on the call? You're on mute.
I can't see the participants with us, but they should be, hopefully.
Okay. Hopefully they'll join us in a little bit when we get to that section. So next slide. Just to say before we kind of launch into talking about this project, this is all about perinatal mental health, and I just wanted to highlight really that, you know, some of you on the call may have had a baby yourself, or may have, you know, be a partner and have had a baby in your relationship, or you know, everyone's been parented at some point in their life, so it might be a bit of a sensitive topic, and just if you need to do what you do to take care of yourself, you feel free to step away. When we're talking about mental health and this period of life, we appreciate that people can be quite vulnerable. I mean, I've just had a baby myself, so I can very much talk firsthand now about the ups and downs of becoming a mother, and just do what you need to do to look after yourself if that's something that you know, potentially feel triggered by in terms of your own experiences. Next slide. So I'm just going to talk a bit about why we're doing this project, and then talk a bit about the aims and objectives. So just a very quick introduction to perinatal mental health. So perinatal, it means around the time relating to birth, and in this project we've defined that as pregnancy, birth, and then 2 years after having a baby. Though the postpartum period, kind of, some services define that as 1 year, some define it as 2. We've gone with 2 years postpartum to cover the perinatal period. And it's a really unique time because, you know, there's lots of change to people's sense of like structure and routine, a sense of like who they are in their sense of self, in that sense of identity that might shift. It can bring up for a lot of people in terms of their own parenting experiences and their own families. There can be some relational traumas where, you know, those difficulties might be ongoing or they might be historical. And there's a real sense of, you know, some things you might want to do the same when you become a parent in relation to your own experiences, and some things you might want to do really differently. And sometimes if you've not had, you know, the role model in your life that kind of provides that example of what the kind of mother you want to be, that can be really tricky to navigate. It's also just a really tricky time physically, like you're going through a lot of physical changes, you've got all the hormones. Anyone who's given birth or watched a scene from a television film or series about a birth, you know, it's not always sunshine and rainbows, and then you have a little human to take care of, and so there's so much adjustment that comes with that, and there's a lot of vulnerability during that time as well. And so the perinatal period can be a really good opportunity. You know, it provides a real window of opportunity for intervention, because it's a real time of change and wanting to do things differently and kind of breaking the cycle of what you might have had historically. And And the impacts of that are wide-ranging and multifaceted, because it's not only about the impact on the mum, but also the impact on baby, and the sort of their longer-term outcomes in life. So it's a really, really great time to be doing research in this area, and for doing interventions at this time in people's lives. Next slide, please. We know, however, that there are some barriers in the road in terms of accessing support for perinatal mental health, and that's particularly the case for different underserved groups. So the latest Embrace UK report showed that there's certain groups that are not represented in services and have, you know, disproportionately worse outcomes in terms of their maternal health and mental health. So Black women, for example, are 4 times more likely than and Asian women are 2 times more likely than white women to die during the perinatal period. And some of the research has shown that that can be due to language barriers, stigma and cultural barriers. The learning disability and neurodivergent community also report that they feel like they can't have a baby because of that diagnosis, let alone access spaces for neurotypical people. And a lot of that is underpinned by a fear of when you are struggling with your mental health, or maybe have that label of being neurodivergent or having a learning disability, there's that sense of, you know, a service is going to take my baby away from me. There's that pressure that someone might put on themselves during pregnancy and the postnatal period to be the perfect mum, to meet all their baby's needs. And so we know that people then don't access services because of that fear and because of that stigma, as well as things like not maybe speaking English, struggling to advocate for yourself during appointments, not meeting the threshold for certain services. And we know as well that there are gaps between primary and secondary mental health services in the UK. So where a lot of people might go to like talking therapies as a primary care option, they might be deemed too severe or complex for a service like that, but then not meet the threshold for a secondary care mental health service like the specialist perinatal teams. And so there's this kind of gap in service provision at the moment where people fall through the net and are really struggling but not able to access support. And then you've got the additional barriers associated with being from an underserved group, like a language barrier or a learning disability, that might further prevent you from accessing the right support at the right time. Next slide, please. So this is where the PRAMS project comes in. So we're a partnership of 6 organisations, which are on the slide there, and we've got a real mix of NHS, university, council and third sector organisations all involved in this project. We also have a brilliant PPI group, so that's the Patient and Public Involvement Panel. That's a group of women who are from different backgrounds, representing different underserved communities, who also have lived experience of perinatal mental health struggles. And then we have a project steering committee group as well. We're funded by the NIHR 3 Schools mental health programme, and we started in October last year and are due to finish in March next year. And our aim is to deliver an experience-based co-designed intervention for underserved women with unmet perinatal mental health needs. So essentially we're wanting to co-design an intervention to serve the women who I was just talking about in that previous slide, who might fall between the cracks in the existing service pathway for perinatal care. Next slide, please. So very quickly, the methods of how we're doing that project and how we're sort of meeting that aim, and then Naseeb's going to talk through the initial findings so far. So the first work package was a national online staff survey and semi-structured interviews, where we essentially sent a survey out to anyone working in perinatal services, whether that was mental health or sort of general maternity care or primary care, so GPs, that sort of thing. Anyone who kind of worked with someone at some point in their perinatal journey, to get staff experiences and perspectives on some of the barriers that they find to providing mental health services and mental health support in that time, and what some of the kind of ideas might be for ways in which we can improve. And then we did some semi-structured interviews with a sample of 19 professionals to explore their views in more detail. The second work package was a series of focus groups and one-to-one interviews with women from underserved community groups. So we did that with a real range of 50 women from lots of different backgrounds, different ethnicities, different areas across Sheffield and Doncaster. Different experiences across the perinatal journey from pregnancy, birth and through to the postpartum period. And the recruitment of those women was through the community research link worker model, where we essentially trained 4 community link workers who are from the underserved communities who we were trying to reach, already embedded within the existing community networks and community groups. We provided training to them on research and perinatal mental health, and then they helped to recruit women to the workshops with the relevant sort of who met our eligibility criteria. And then the third work package, which is the bit we're doing currently, is a series of co-design workshops where we bring people together from work packages 1 and 2 to co-design a bespoke sort of middle level intervention for perinatal mental health. Next slide. So I'll hand over to Naseeb and Danielle now, who are going to go through the work package 1 findings. I think you're on mute, Naseeb.
Thanks. Yeah, I'll just go through work package 1 first. So this was an online survey that was opened for 3 months from February to April 2025, targeting professionals working with perinatal women and birthing people. We did open that up further into the survey being open to open up more nationally. And we did targeted recruitment at research sites, so Sheffield Children's Hospital, Sheffield Health and Social Care and Sheffield Teaching Hospital. We also circulated the survey through professional networks with project management groups and known forums such as NHS Futures. And the survey kind of consisted of screening questions about their role, their organisation, and what kind of underserved groups they interacted with. And it was also made up of the PCAT 14, which is the Pragmatic Context Assessment Tool, which asks statements, and you're asked to rate them how much they're a facilitator or a barrier to change in your service. And then, as Elena mentioned, we did do targeted follow-up with professionals to do interviews with them as well. And then work package 2, as Elena mentioned, was the focus groups with women with lived experience, and these were recruited through community research link workers, and we recruited them from emotional wellbeing clinics and family hubs, local family hubs like peer support groups in Sheffield and Doncaster, and also personal community networks, which was helped through the link workers as well. We delivered 8 focus groups from May to August 2025, and held 3 one-to-one interviews. So some women weren't comfortable with discussing their experiences in a group, so we did offer that option of doing a one-to-one interview as well. And we kind of held these in community venues. So we did a focus group in a mosque, in family hubs, we did some home visits, and we also did them online as well. And overall, we spoke to 50 women, which was a good recruitment target. And then, yeah, Elena mentioned work package 3, which was the co-design phase. So we did the quantitative and qualitative analysis in September. We completed that and kind of triangulated our work package 1, work package 2 findings throughout October, which informed the co-design workshops and the content for those, which we're currently doing at the moment. And then, yeah, taking things forward, we'll be conducting implementation workshops in February and kind of finalise the intervention, and then doing a final celebration event in March. So yeah, I'll go through the findings of work package 1 and 2. So for the survey findings, our final recruitment figures were 130 professionals consented, and 113 of those were full responses that we included in the analysis. And that gap in the figures there is just because some people consented to the survey but didn't complete at least one statement from the PCAT 14, which is what our definition was for a full response. Respondents-wise, majority were from Yorkshire, just because that was the majority of the time it was open just to people in Yorkshire, but then we opened it up nationally in the UK. So 78% in Yorkshire, and then a few smaller numbers in northwest of England, east of England, London, and the south. And the majority, 75.2% of participants who responded, said that their service had made special arrangements to improve access for underserved patients. And that table there just shows a breakdown of the types of roles that responded to the survey. The most common being health visitors, midwives and GPs, and then we got some clinical psychologists, nurses, service delivery managers as well. And so yeah, just a few of the roles there that responded. So these graphs kind of show the findings from the PCAT 14. So as I mentioned earlier, these are kind of asking people to rate the statements on the side here based on how strong of a facilitator it would be or a barrier it would be to implementing change in their service. The bigger the green bar means it's a stronger facilitator, and the bigger the red bar means it's a stronger barrier. So, for example, the statement here, people here regularly seek to understand the needs of patients and make changes to better those needs. That was rated mostly as a strong facilitator. So most people that responded said that that was in their service, it was a facilitator to implementing change. And then also the change is aligned with clinician values. That was also rated as a strong facilitator to implementing change. And these are all kind of factors that we should implement into our co-design intervention and kind of consider when implementing it into services. And then the rest of these statements are shown here. So for example, we can see a bit more of the red bars. So resources, space and time were cited as big barriers to implementing change. I think that's common in most services in the NHS. So yeah, it was good to see that depicted in the graph as well. And then for work package 1, so I'll go through the kind of overall themes collated with the work package 2 focus groups as well in the next few slides. But just to reiterate, we completed 19 interviews with professionals, and those roles kind of included clinical psychologists, specialist perinatal staff, cognitive behavioural therapists, peer support workers, nurses, psychiatrists, health visitors. So we kind of aimed to sample a wide variety of different roles to kind of get a range of different experiences. And we've pulled out some quotes there to kind of illustrate some of the things that came out of those interviews. And one of them being that, it's hard to keep up with just the basic job sometimes, and adding like adaptations and addressing underserved barriers and stuff that can sometimes be quite overwhelming for the staff as well. So it's just, interesting to see those quotes there. And then work package 2, as I mentioned, we spoke with 50 women across a range of communities and served groups. This just kind of shows some of the communities and groups that we spoke to. So we tried to sample from ethnic minority backgrounds and religious minorities. We also did some focus groups with non-English speakers. So we kind of used interpreters in those focus groups. Young mums and single mums, mums with physical health morbidities, neurodivergent mums, spoke with a carer, and just a range of different mental health presentations as well, including anxiety, birth trauma, pregnancy loss. So we got a kind of a range of different experiences in those focus groups. I'll hand over, if Sahar and Kathleen are with us, I'm not sure, but they can speak a little bit about their experience on the focus groups. If not, I can move on to the next slide.
I don't think they're on the call yet, Naseeb, but we've just sent them an email to check they've got the link.
Okay.
And Kelly's doing that in the background as well. So if we just move on for now, and then hopefully towards the end of the presentation they can join and just speak to their experience.
Yeah, thank you. So yeah, like I said, I'll go through the different themes that came out of both the interviews and the focus groups. So when we did the analysis, we coded this on the candidacy framework, which is shown here, and coded it to the 7 different domains on the side there. The candidacy framework just kind of goes through the service pathway journey for a user from the point of identification of their own candidacy for support all the way to offers of treatment. So yeah, I'll start with the first one being identification. So this is how people identify themselves as suitable or eligible for services. So we found when we spoke with professionals and also women with lived experience, a lot of them identified their need for support quite late into their mental health journey. So even sometimes presenting at their crisis point. So this late presentation might be due to a number of factors, maybe even cultural help seeking patterns. So I know there's stigma within certain communities about mental health, or not wanting to seem weak, or wanting to kind of deal with their issues within households or families. So that kind of delays that help seeking pattern. We also found that those with moderate to severe needs were more likely to be picked up by professionals during routine appointments and identified then and then referred for specialist support, whereas those with milder to moderate concerns were more dependent on self-referral processes, so kind of identifying themselves as needing support and going forward themselves and finding that support. And then we also asked professionals whether there were any groups that they kind of didn't see or they thought were underserved or had unmet needs because they didn't kind of see them in their service as much. And those were identified as people going through care, people with complex trauma histories, and cultures where families kind of want to take charge and manage it, as I mentioned earlier, young mums, migrant groups, and non-English speakers were all identified as groups that potentially had unmet needs or weren't identified as people identifying themselves as candidates for services. And then navigation, so how people find their way to appropriate services. So we spoke a little bit about referral systems. Professionals sometimes cited they were limited in who gets referred to them. So for example, psychiatrists who work in hospitals are kind of limited in other services referring women to them. They also mentioned that self-referral was unlikely in some groups and that outreach work was really important for this. So kind of going into the community and spreading awareness about services that were available, spreading awareness about the importance of mental health, and encouraging women to come forward. Referral systems were also reliant on women raising concerns or staff noticing those issues. This can also be dependent on appointment attendance to be picked up, and some women from underserved groups might not attend appointments for a variety of different reasons. So health visitors reported better experience picking up women who may need support as they see those people and they can build that trust with them, so they can have repeated conversations about mental health. And because they see that women consistently, then they can more likely identify if anything's going wrong, if they're having difficulties. And then again, like I mentioned, outreach to community came out as a really important theme in kind of getting people into services. So peer support workers, for example, highlighted they had a lot of success in getting women to access their service after they did community outreach work. So that was really important, raising awareness of their service and the support available. So the next domain was permeability of services. So how easy it is to get through to the actual service and get support. So we found that with our focus groups, setting had an impact. So when some women didn't want to be seen attending a mental health service or kind of a mental health official building, and cited that community locations were better for this. They also said that emergency departments were off-putting, for example, the noise and the wait times. So people presenting with crisis, for example, might not present at emergency departments. Barriers to access were cost to travel, so cost to travel to appointments, for example, taxis or bus fares. Language barriers, so not being able to convey properly what they're feeling in their own language. Distrust of healthcare systems, feeling overwhelmed in the perinatal period, so having to take care of a newborn baby and everything that comes with that. Sometimes mental health was deprioritised or just not seen as a priority at that point. Separation from their partner, so when some women didn't want to be separated from their partner when accessing mental health support. Fear of judgment, particularly with the young mum group. Cultural stigma, fear of baby being taken away was a really common theme within focus groups. So that fear of social services or consequences of like things that they might say in appointments, so not having that safe space. And appointment scheduling, creating anxiety and burden as well. So like I said, having to take care of a newborn baby, sometimes having that extra burden of scheduling appointments is a barrier to accessing support. But then facilitators to access were flexible delivery methods, so offering support through text and home visits, group sessions and phone calls. So having those different formats available was really welcomed by women. And also multiple therapy options, so having the option of going to a class or having one-to-one counselling or CBT, so cognitive behavioural therapy. And then also they said having an allocated worker, so having that continuity of care, that consistency with having that one person that you can see and having the opportunity to build trust with that person and having that safe space to kind of have those conversations on mental health. So I'll hand over to Danielle to speak about the rest of the domains.
Thanks, Naseeb. Yeah, so in terms of how people present themselves to services and what their needs are, when it came to assessment, people felt as though the standard of assessments might be a barrier, and they can sometimes feel a bit tick boxy and perhaps not enabling people to express what their needs are, or needs might go unidentified because of fitting into sort of a more rigid assessment criteria. And then also, if their needs didn't fit into this rigid assessment criteria, that then requiring a lot more confidence on the part of the service user to advocate for their needs, or somebody advocating for them, and those language barriers being quite key in terms of being able to build that trust and have that confidence to assert what those needs are. So that being really important in terms of people being effectively communicate those needs. And then not meeting the criteria. So it was established that there is a need for, when people don't meet the criteria, they are falling between those gaps, that the responses by services is considered and sensitive, so that people don't just feel like they are falling between the gaps in services and not knowing where to turn for support. And then in terms of professional validation, a feeling that when they feel listened to by professionals, that feels really powerful in terms of feeling validated in what the experience they're having, and especially where there might be family dismissal of concerns as being just moody or hormonal, and in cases where people might be masking their difficulties in response to that, feeling like they have to manage by themselves, that actually feeling listened to by professionals, and that kind of idea of it not being in your head is really important. Thank you. So in terms of how healthcare professionals assess and respond to presentations, a staff training gap was identified in terms of cultural competency and community knowledge, meaning that there was a need for enhanced cultural competency and community specific knowledge. And it wasn't so much that people didn't want to increase their cultural competency and community specific knowledge. It felt as though professionals are very aware of this gap and wanted to be able to do more, but wanted to feel supported to do so through training that felt like it was much more useful in practice. There was kind of a feeling that training often felt a bit tick boxy as well, and not so sort of applicable to the real world setting. And then another training gap in terms of having the conversations about mental health. So again, healthcare professionals such as midwives were really wanting to be able to have those more sensitive conversations, but didn't perhaps feel so confident in addressing that conversation and identifying things that perhaps might go beyond what is spoken or what's communicated in the room with body language, for example, and then also not feeling that they would necessarily be supported if they started to have those conversations, what impact that might have on their own well-being as well. So yeah, so it was just around improving training in how to have those conversations with people about their mental health, in terms of how to ask about it and respond, and the relevant skills for managing concerns and distress. And then complex trauma history. So this kind of idea, coming back to the falling between the gaps in the services, of services feeling as though they have to take a step back from how somebody is presenting because it doesn't fit within the model of what that service is. So yeah, this kind of feeling of going, that's not us, and everybody taking a step back. And then in terms of what is offered and how people respond, so from speaking to people with lived experience, it seemed as though there was a resistance to medication. And sometimes that might have presented a barrier in terms of people wanting to engage with support if they felt as though the treatment they were potentially going to be offered once they engaged with that support was not going to align with the support that they felt would be helpful or meaningful for them. And also feeling as though that had implications of the severity of what they were struggling with, so thinking that they're not curable without tablets. Flexible offers, so emotional well-being and mental health support to mums, but also to the partners, the dads and the family members involved in supporting that person. And then also what that support looks like in terms of whether it's group support, peer support, how it's delivered in terms of maybe via text, via call, email, so flexibility in the delivery, and then the types of offering available depending on what the presentation is. So it might be that psychological support that would be appropriate would be MDR, it might be CBT, it might be DBT, it might include practical support such as housing support and support with benefits as well. And also in terms of the location that people were accessing support. So something that was away from a more clinical setting sometimes might be more appropriate for somebody to feel they were able to engage with that offering. And then also in terms of factors preventing continued engagement. So sometimes people are able to make that engagement with services, but then it becomes tricky to maintain that engagement for various reasons that might be emotional, more practical, in terms of that as we've spoken about a lot, the demand of engaging with the service when you've got a new baby to care for. There being language barriers, the cost of travel, the fear of your baby being taken away, lack of understanding or feeling listened to, and also it being a lot sometimes to engage with the way that the appointments are scheduled, that can feel quite overwhelming in itself. And then inclusion of partners. So we found that it was often quite helpful if support could include partners and also be mindful of family dynamics being very variable from person to person. So then in terms of the broader context affecting how candidacy is constructed, building on that family dynamics point, again, that just having that awareness that it isn't always the family that is supportive or helping a person to be able to engage with that support. Sometimes that can be the barrier to a person accessing support as well. So if there is like kind of cultural implications around accessing support, that might lead to feelings of shame, which then might make it less likely for somebody to engage in that support. And that there being this kind of professional assumption that if somebody is surrounded by lots of family support, then that they are kind of well supported and they don't need that additional input, but kind of looking a bit more deeply into what that family support actually feels like and whether or not it is actually helpful for the person. And then community leaders, so involvement of community leaders being key for implementing a new service for these underserved groups. So somebody that was embedded within a community that understood a community from within rather than somebody external putting an external judgment on what they felt would be appropriate or useful.
I'm just conscious of time, Danielle, so I'm just wondering if we can skip to Kelly's reflection just to kind of summarise based on those findings that we've just, you and Naseeb have just spoken through, just to kind of think about where wrapping it up in terms of where we are now and what that's feeding into, and a final reflection, because I'm just conscious that we've only got half an hour to do, which I think we've already run over, and then the time for Q&A. And just to mention, Claire, I think our PPI representatives tried to access the meeting, but the link's not that I've shared isn't working. So just wondered if there's like a access, should she be able to access it with the link, or do you need to share it as the meeting organizer?
Have you forwarded it to her?
Yeah.
So she should be able to access it. Do you want
Okay.
to maybe send me an email and I can try forward it on?
Yeah, that would be great. Thank you.
Okay.
Right, so I'll just touch upon what we're doing in terms of our final work package 3, and then just give a few reflections on work package 3 so far, but also on the project overall. So we're very much in the midst of this work package at the moment. What are we trying to achieve? What might the finish line look like? So essentially the overall aim of this final work package is to bring together some of our key stakeholders from work packages 1 and 2. So that's both professionals and people with lived experience of perinatal mental health. And we're bringing them together to essentially try and co-design our intervention. And although it's still a little bit unclear exactly what our intervention is going to look like, what we are anticipating is that it's an evidence-based informed framework targeting those who are wanting to address health inequalities in maternity and perinatal mental health care systems. We're sort of focusing on a South Yorkshire footprint for now, given that that's kind of where our input has come from. But we're very much focusing on a system level type intervention rather than something really kind of specific and focused. Because I think we've got so much rich data from work packages 1 and 2 that it feels like it's really appropriate that we use that really rich data to have the biggest impact. And in order to have the biggest impact, we need to sort of develop something system level. So that's the intention with our intervention, although the actual content of it is still obviously being determined by our co-design workshops. Just for kind of context as well, I know I think Naseeb touched on this earlier. We've had an online introductory meeting as part of this co-design phase, where we invited all the key stakeholders to attend that meeting. The aim of that was really just to kind of reintroduce the project, reintroduce what we're intending to do, summarize some of the key findings as we have done today, and then start thinking about actually what the co-design bit is going to look like. We've then had our first co-design workshop. That was last week. That was face-to-face, and that's when we've started to kind of really go deep dive into, right, what actually is this intervention going to look like. We've got another co-design workshop on Thursday this week, and then our final one is in January. So we're still very much in the midst of this phase. Next slide, Naseeb. And this is just kind of orientating in terms of exactly where we are. So really what I've just described. So we are in that sort of co-design workshop phase at the minute, exactly halfway through actually, and then we will be having a celebration event where we'll be inviting all the stakeholders to come and hopefully see the final product, and also, you know, celebrate the work we've done over the last 18 months. So just in terms of some reflections of what we felt has worked well during the project so far. So we've had really good teamwork as part of our project management group. We've got a real breadth of experience in our project management group. So we meet on a monthly basis, and any kind of issues or challenges that we're having, we've been able to kind of talk through them with our PMG members and get solutions to some of those, but also just really helpful ideas, thoughts about how we can deliver the project, and as a result there's been kind of a bit of an iterative element throughout the project as well, which has been really good. We've also had this sort of novel, innovative approach to recruiting underserved women. So we've had our community research link workers that we've just described, who have been absolutely pivotal in enabling us to recruit the women that we really wanted to hear from, that we rarely do hear from because of all the barriers that we've described already. So that's been absolutely amazing, and we couldn't have done the project, and we wouldn't have anywhere near as rich information without our community research link workers. So that's been really essential. And as a result of that, we've actually surpassed some of our recruitment targets, which has been great, and we've managed to kind of tap into a real range of underserved groups as well, which has also been really helpful for the project and informing the final intervention. And then we've also had co-design kind of weaved throughout this project as well. So obviously the co-design phase is very heavily centered in co-design, but throughout the projects we've also had really good engagement from our patient public involvement panel and our project steering committee as well, who have helped really sort of drive the project forward and give suggestions and thoughts about how we can do things differently as well, which has been really helpful. And then just a couple of reflections on the co-design phase so far. I think one of the things that we've managed to do is, so far we've been able to get some really rich data from these co-design workshops, and I think that's kind of a testament to the fact we've managed to enable a really safe space, and women have felt able to open up and discuss some, you know, quite tricky experiences, which I think has really been a huge positive. I think one of the things we've maybe struggled a little bit so far is engagement with professionals in the co-design workshops. We've had great engagement from our people with lived experience of perinatal mental health, but it's been a bit more challenging getting professionals involved, and I think that's purely just pragmatic. It's just the time of year. It's a really busy time of year clinically and personally, and with it being face-to-face as well, I think that's probably maybe an extra barrier, so maybe something for us to reflect on. But what it has meant is we're kind of thinking a bit differently about how we can approach the professionals and how we can get their involvement slightly later down the line in the project, thinking about the implementation and more the how can we kind of, once we've got a bit of a framework in some key principles or the framework there, actually how can we action some of those things, and so that'll be where I think the professional involvement will be really key. And then finally, just this idea of trusting the process. I think, you know, for us it's still a little bit unclear what the final intervention is going to look like, the final product, but that's okay. You know, this is part of the co-design process, and you know, we've had to be really flexible, we've had to adapt continually. We're still doing that right now, and I think, you know, that, like I say, that's okay, and that's kind of part of this project and part of this work. So I don't think
Tasleem's joined the call, so I'm forever conscious, Claire, that we've run over on the amount of time that we should have been talking for, which is my fault for joining a little bit late and talking too much at the beginning.
If you want to carry on, it's not a problem at all.
Oh, so, thank you.
Tasleem, do you want to, if you feel able, do you want to just give a few reflections on your work on the project?
Yeah. First of all, I'd like to apologise. I had a problem joining on the thingy. link. Yeah, so I felt that the feedback I got from women, it was that they felt very safe. They felt it was a safe place where they could talk, and it was also that they felt that before this, they never heard of the word research. They didn't know what it meant, and when I explained it, and they wanted to join. So once they joined, I got good feedback from them, saying that they felt very listened to. They felt the empathy, and so they also felt it was more of a counseling session for them as well as research. So and now they keep asking me, when are we doing the next one? So they enjoyed it so much that they're looking forward to some more workshops in future. So I think overall it's been a good positive effect from the women. And I think because they had language barriers, so not many would have joined if, like, for example, I wasn't there for interpreter, or somebody wasn't there to, translate for them. They wouldn't have, even thought about joining. But they felt that, because of the language barrier, that the research they did, they felt that they've thought about it, thought about the language barriers, and thought about those women that wouldn't otherwise get involved in research like this.
Great, thank you so much, Tasleem, for sharing. Eleanor, are you closing off?
Yeah,
Yeah.
I'm just checking to see if Sarah's joined, but I don't think she has, which is a shame, but thank you so much, Tasleem, for sharing. And it has just been such a positive experience having someone like Tasleem as a key member of our project, because as Kelly said earlier, we couldn't have done it without her, put simply. So thank you, Tasleem.
No, I think they couldn't have done it without you, really. Yeah.
So yeah, thank you everyone for listening. If you want to follow our progress for the project, we've put the website link there and a QR code, and we've also put our contact email addresses on the slide there. But yeah, happy to take any questions from the room about the project. And yeah, apologies that we kind of sped up the last part of the presentation. Again, my fault for talking too much. So yeah, open to the floor really for any questions.
Thank you ever so much, all of you. Very much a team effort. You can see that, and no need to apologise at all. It's been fascinating. I don't know if anybody's got any questions at all from the attendees. I suppose, the question is, what's next?
So right now we're doing the co-design workshop. So we've got our third workshop on Thursday this week, and then the last one in January. And as Kelly sort of spoke to, we're very much in the thick of deciding on the content of our intervention, and we're very much just trying to trust the process of co-design, because it still feels a little bit woolly at the moment as to what the content of that's going to be. But right now we kind of have an idea that it's hopefully going to be some kind of framework that anyone who's wanting to make changes to their service or their organisation or the way that things are done wherever they are to improve access for underserved groups in the perinatal period, then they can take our framework and apply some of the principles and the values and the action points that will be part of our framework based on our research. That's where we're heading, but in terms of the initial next steps, that's what we're doing.
It'll be a fantastic resource when it's developed. I think Violet's got a question also.
Yeah, I'm just listening to I think Kelly said it about the challenge with the professionals, not being able to get like all of them in essence for the workshops. I'm wondering if you can give maybe like a few different dates and times, sessions that you could have. So you might not be able to meet all of the professionals at the same time, but if you can get like them in small groups and still get some output from that, I think that would be useful. And then I guess from with the first group, you only get what they have to contribute. But I guess if you have like the second and the third groups, you can also take what you what you gained from the previous group, present that to the second group, for example, professionals, and that way it's almost as if all of their opinions were in the room and they get the chance to like share their opinions on like those different thoughts of co-design output and different things. I just thought there might be an idea to overcome that barrier if you just present like a couple of dates.
Yeah, I think that's a really helpful suggestion. Thank you. I think one of the things, so the workshops, how we've sort of organised them is ideally we wanted people to attend all 4 workshops, so the introductory session and then the kind of 3 more kind of co-design elements of the workshops. But we've also said, you know, you can attend as many or as few as you can manage, acknowledging again, you know, the time of year. It's a super busy time of year for lots of people. So we, you know, we just wanted as many participants as possible. But one of the other things we were discussing actually in our project management group meeting yesterday was to maybe link into some existing network meetings that we've been engaging with. So some of our kind of local South Yorkshire networks, and as you say, sort of presenting some of those initial kind of thoughts and ideas to those groups and get some feedback from those groups as well. So rather than trying to organise a separate meeting, kind of piggybacking onto existing meetings, where we know there's a range of professionals that attend those sessions, and then we can hopefully get some kind of further input, particularly, as I said, around the kind of almost the implementation part of it as well. So it's kind of all well and good having some kind of big key principles or a sort of an overarching framework, but then actually how do you translate that into change and actual, you know, shifts in practice? That element I think would be really key to get the professional engagement with. So Eleanor, I don't know if you've got anything else to add to that or.
No, I think you answered that really well.
We've got a question in the chat as well from Ms. Sal. It says, how do patterns of inequality and access to perinatal mental health services in your local area compare with national trends?
So the survey that we did at the beginning with the professionals, that's drawn some data on which across different services, which professionals kind of identify different underserved groups as being the ones that they maybe see more in services and less in their service. And our statistician is doing the analysis to kind of compare that to the national survey data as well. But I think I don't know off the top of my head how it directly compares in terms of different groups, but the slide I showed at the beginning about you know, Black women being 4 times more likely to die and Asian women being 2 times more likely to die than white women in the perinatal period, I think that holds true for us locally as well, in terms of those, you know, being ethnicity being a key factor in or a key sort of protected characteristic in terms of who we don't tend to see in services as much. And just, I guess, reflecting on my own experience of working in the specialist perinatal mental health team in Sheffield, there's definitely a sort of an imbalance in terms of the ethnicity and the demographics within our service. And so we know that there are people who fall between the cracks and don't make it even like a referral to our service, but even out of the referrals that we do get, it's not representative of, you know, the demographic in Sheffield more broadly. But I don't have any like specific numbers off the top of my head. We do have a statistics report that kind of breaks it down in more detail, but yeah, I can get in touch with you, Marcel, if you want more kind of specific answer to that question. But yeah, Kelly, Naseeb, I don't know if you've got any further.
I suppose the only thing to add is that, so we were kind of looking across South Yorkshire as well. A lot was Sheffield focused, but we did go broader as well across South Yorkshire. And even within South Yorkshire, there's so much variability from a demographics perspective. Yeah. So Sheffield is a really diverse city in South Yorkshire. whereas in kind of Barnsley, Rotherham, Doncaster, it's much less diverse. It's much more heavily kind of weighted towards white British, if we think about ethnicity, for example, but overall really deprived places compared to the national average. So all of those are going to factor into the inequalities we see in South Yorkshire. So just, yeah, not specific around perinatal inequalities, but we know that, you know, deprivation, ethnicity feeds in, they're the drivers for those perinatal mental health inequalities.
Well, I think that's it. Absolutely fantastic. Thank you so much, all of you, and go back and enjoy your maternity leave.
Thank you.
Thank you ever so much for joining us.
No problem. Thank you so much for the opportunity to present.
I hope everybody has a lovely Christmas.